هو ده دليل بصراحة إن إيه، إن يعني I usually enjoy the discussion after the speech، يعني إيه لدرجة تقريبا مساوية لماي انجويمنت للكلام اللي هو بيتقال في المحاضرات. فيعني إيه this is very important و should be. يعني أنا نفسي، يعني حضرت محاضرات كتيرة قوي عن الimmunization of the immunocompromised, immunization of the hematological disease immunization، لكن يعني انا نفسي انها تبقى حاجه available في ايدي، تبقى يعني ايه something to be touched، بحيث ان انا على طول تبقى ايه لما حد يكلمني بالتليفون حتى اقول له لا المفروض يحصل كذا 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 على طول يعني. فشكرا.
شكرا لحضرتك دكتور ماجد بيه. طبعا انا اعيد الترحيب بالاستاذه الدكتوره ايمان سيدهم، استاذ ورئيس وحده اورام الاطفال في الان سي اي ناشونال كانسر انستيتيوت ومستشفى 57 طبعا وجودها النهارده بيثري الجلسه وبيثري المناقشه، خصوصا ان الموضوعات اللي هتتقال كلها يعني very hot topics يعني.
بس كان المفروض تنبهونا برضه.
اشكرك يعني بجد for a very nice introduction. actually ليا الشرف الحقيقه في وجود اساتذه عظماء وفي وجودي في وسطيكم. It's my great pleasure to introduce our next speaker, Professor Dr. Dalia Helmy. She will be talking on hereditary angioedema. Physician awareness is life-saving.
Thank you, Dr. Iman, for your nice introduction. Bismillah ar-Rahman ar-Rahim. My talk will be about a very overlooked disease, a rare immunological disorder that commonly misdiagnosed with a consequent high morbidity and mortality, and that's why physician awareness is life-saving, as we will see. I have nothing to disclose. The agenda of my talk will include the definition and pathogenesis of hereditary angioedema, clinical presentation of hereditary angioedema, its diagnosis, diagnostic workup and differential diagnosis, treatment and disease burden of this disorder. So before going through the hereditary angioedema, I would like to stress what should a rare disease mean to a medical community. This should be, we have to emphasize that a rare disease should be met with the need to create a specialized medical center that for management of this patient. Collaboration is required to allow adequate sample size in order to develop and validate an outcome measure for the disease, to evaluate the disease status and hence tailor the treatment, evaluate the efficacy of new treatment in randomized controlled trials using a feasible validated outcome, and efforts should be made to provide validated information for healthcare payers to make effective but expensive orphan medicine available with reimbursement. So starting with the definition of hereditary angioedema, this is a rare genetic disorder characterized by intermittent recurrent vascular edema, what's called angioedema, in the mucosal and submucosal tissue or in the dermis and subcutis. Hereditary angioedema is generally an autosomal dominant disease, so family history is very helpful, but negative family history cannot exclude the disease, as nearly 25% of these patients represent de novo mutation, so family history is negative. Coming with the nomenclature and classification of hereditary angioedema, we can find that there is hereditary angioedema. Hereditary, I don't think that it is مش واضح قوي، مش شايفه هنا بس ممكن use the arrow. The hereditary angioedema, this one, ازاي بقى كده؟ The hereditary angioedema with defect in the C1 esterase inhibitor, and this includes two types. Hereditary angioedema type 1, which represent deficiency in the antigenic level and function of C1 esterase inhibitor, and this is the majority. And hereditary angioedema type 2, which represent a normal or even elevated level of C1 esterase inhibitor, yet with defective function. And this is represent nearly 15% of the cases with defective C1 esterase inhibitor. Otherwise, hereditary angioedema with normal C1 inhibitor esterase These patients have normal C1 inhibitor antigenic level and functions, and their underlying pathogenic mechanism involved other molecules like some sort of mutation in the factor 12 angiopoietin 1 gene, plasminogen gene, kininogen, myofrelin, heparan sulfate, glucosamine, and remainder there is a minority with unknown genetic mutation. This genetic mutation involve either the unopposed activation of the contact system and the fibrinolytic system, or involved with the defective vascular permeability, resulting in angioedema. So going through the pathogenesis of this disorder started with factor 12 in contact with a negative anionic surfaces, like polyphosphate, like some interaction with collagen, bacterial polysaccharides, which are then activated to active factor 12 that will stimulate the prekallikrein activation into kallikrein that through contact with the high molecular weight kininogen will result in production of bradykinin, then acting on the bradykinin receptor on the endothelial cells, resulting in production of the nitrous oxide prostaglandin E2 vascular endothelial growth factor, and resulting in vasodilation, increased vascular permeability, and pain. Also, prekallikrein can be directly activated through contact with the heat shock protein 90, which is non-esterase protein, stress protein, produced in response to estrogen, interleukin-1, tumor necrosis factor alpha. At the same time, the prekallikrein goes through activation of the plasminogen into plasmin directly, and through production of the urokinase plasminogen activator from pro-urokinase, resulting in excessive activation of plasminogen into the plasmin. Also, kallikrein and plasmin exert positive feedback loop on factor 12 to be activated into active factor 12, which then goes through autocleavage into the beta fragment of factor 12 that loses its procoagulant activity, but acting through the complement system, mainly C1R and C1S, the esterase complex of complement 1, resulting in its activation that will act on C4, resulting in excessive activation and cleavage of C4. So this fibrinolytic contact and complement system under normal condition is kept in homeostasis through the presence of C1 esterase inhibitor that maintain every step in under control. So in case of C1 esterase inhibitor defect, whether in the level or the function, there is excessive activation of factor 12 into active factor 12 that will excessively induce the activation of prekallikrein into kallikrein, and as well the production of the bradykinin. Also, there is defective inhibition of the activation of the plasminogen into the plasmin, which is then increased, exerting heightened positive feedback loop on active factor or on factor 12. Also, the C1 inhibitor here and the lack of suppression of a beta fragment of factor 12 will result in excessive stimulation of C1R, C1S, with the resultant decreased C4 that is characteristic in patients with C1 and inhibitor defective hereditary angioedema. This will result in excessive vasodilation, excessive increased vascular permeability, with the associated pain of this disorder, resulting in bradykinin-mediated angioedema. Therefore, in hereditary angioedema, we note that now there is activation of the entire coagulation cascade, or as well as with increased fibrinolysis, explaining the strikingly elevated D-dimer level, reflecting disease activity. The D-dimer is increased in this patient, even in between attacks, but more related with the disease activity. However, in vivo thrombosis is not seen in patients with hereditary angioedema. So although there is activation of the coagulation fibrinolytic system, this patient has no described hematological disorder. It's pure immunological. And one possible explanation that might be the rate and concentration of thrombin produced in the presence of inhibitor like antithrombin 3 might prevent thrombotic event and avoiding the any thrombophilic risk for these patients. Coming to the clinical presentation, this patient typically becomes symptomatic during childhood, nearly by the age of 10 years, or maybe by the young adulthood around the age of 20. And the hallmark of this disorder is recurrent angioedema, causing cutaneous swellings, abdominal symptom from gastrointestinal angioedema, and the most life-threatening respiratory symptoms due to airway involvement. Attacks are characteristically unpredictable in frequency, severity, and location in the same patient and between different patients in the same family. Attacks usually characteristic begin slowly, peaking around after 12 to 24 hours, and can last from 3 to 5 days from the start to resolution of the symptoms. However, with considerable morbidity and mortality if untreated. And it's very important to note that persistent swellings for weeks or longer is not consistent with hereditary angioedema. So it comes in attacks, most commonly not beyond 5 days. Hereditary angioedema symptoms do not respond to medications used to treat allergic angioedema, where antihistamine, corticosteroids, or epinephrine, as well as omalizumab, do not have any effect on the course or the resolution of hereditary angioedema attacks. These patients, some of these patients, like nearly like 25 to 50% of these patients might have prodromal symptoms that can sometimes precede the attacks, like several hours, and include mood changes, sense of inner unease, restlessness, nervousness, fatigue, malaise, disability, feeling tingling sensation at the initial site to be affected, and they might have erythema marginatum, which is like we can see here, macular and evanescent non-periodic rashes, usually misdiagnosed as urticaria, resulting in delayed diagnosis of this patient and giving incorrect management. So the cutaneous involvement is very common, commonly affecting the extremities, nearly 90% of this patient, second followed by face in 70% of the cases, might affect genitals, buttocks, causing temporary disability and disfiguring. It is not associated with urticaria or pruritus, but some might have erythema marginatum over the affected limb or anywhere else in his body. Gastrointestinal involvement are extremely common, occurring in majority of patients, 93%. Sometimes the gastrointestinal attacks occur without any associated cutaneous and or respiratory involvement, which might complicate the early recognition of this disorder because it enters in the differential diagnosis of acute abdomen. They can present with recurrent episodes of abdominal pain, abdominal distension, nausea, repetitive episode of vomiting and diarrhea that might reach up to 25 times during a single attack, resulting in might be in circulatory collapse. If we coming to the characteristic of this abdominal pain, can see that it might in phase 0, it is maybe associated with or preceded by the prodromal symptoms. Then like 2 to 3 hours, the patient might have non-abdominal pain symptoms of feeling satiety, abdominal distension, nauseating. Then there is the crescendo phase, lasting like 3 to 4 hours. It is the time from the first feeling of the initial crampy abdominal pain to reaching the peak, the maximum peak of feeling this crampy abdominal pain. Then we can see that this is the plateau phase. It lasts like 24 hours. The patient is suffering from the maximum severe abdominal pain, and then it takes like 2 to 3 days to resolve and end of this attack. And we can see this CT, okay, showing like ascites. And this is what's called the stacked coin appearance, reflecting mucosal edema. We can see that there is no abdominal lymphadenopathy, no altered signal infiltration of any organ adjacent to the intestine. So it is just like bowel wall edema with intraperitoneal fluid collection. And this is a patient who presented with severe abdominal pain and picture of intestinal obstructions. And they did colonoscopy during an acute attack showing severe mucosal edema in the transverse colon with occlusion of the lumen. We can see that there is no ulceration No any abnormality in the mucosa to differentiate it from other disorder of the GIT, the primary gastrointestinal disorder. HAE attack of HAE attack of the oropharynx and or the tongue can cause asphyxia in severe cases. In untreated severe cases, circulatory collapse, bloody diarrhea, and intussusception can occur. Upper airway involvement, which is the most serious manifestation because of the occurrence of laryngeal edema. It can occur like in 50% of the patient at least once through his life. But it unfortunately, although it is not that common, but it is life-threatening and account for the highest mortality because of this disorder. In mild cases, it might present as dysphonia, stridor, and in severe cases, respiratory distress and asphyxiation. And you can see this is next CT revealing laryngeal edema and no other abnormality in the adjacent structures, reflecting this is submucosal edema and no, like excluding other differential diagnoses. And most deaths occur with de novo cases and with lack of awareness about hereditary angioedema. They tend to give anti-allergic medication without any single response. Because of the worsening of hereditary angioedema with even any minor trauma, if the patient is delayed in management and intubation is delayed to save this patient, it will be very difficult to save these patients through intubation, and that's why we will see in the treatment of this patient when to introduce emergency life-saving management. A variety of conditions are known to trigger this attack, like trauma, whether accidental or associated with invasive dental, medical, and surgical procedure. Some drugs like the ACE inhibitor, because they inhibit the enzyme causing degradation of the bradykinin, resulting in excessive bradykinin production and accumulation, causing the devastating pathogenic mechanism, underlying pathogenic mechanism of hereditary angioedema. Estrogen-containing medications may trigger the attacks because this estrogen, in many times, activation of factor 12 is estrogen sensitive, and it might some sort exacerbate the occurrence of the cascade involved in hereditary angioedema pathogenesis. Psychological stress, fatigue, febrile illness. This is because there is activation of factor 12 when it contact with a negative anionic surface, or with the psychological stress and stimulation of production of the heat shock protein. And all patients with hereditary angioedema should be educated about triggers that may induce attack as far as possible as they can to avoid these triggers. So what about the diagnostic workup of hereditary angioedema? In case of clinical suspicion of hereditary angioedema, which means by recurrent angioedema attacks, that no response to anti-allergic medication, positive family history in this patient, no other abnormalities that associating this disorder in any other structures. So we have to do C1 inhibitor level and function and C4 level. If we have found that the level is less than 50% of the normal and function as well with decreased C4 level, this is consistent with the diagnosis of hereditary angioedema, C1 inhibitor, defective C1 inhibitor type 1. And if the C1 inhibitor level is either normal or increased with defective C1 inhibitor function below 50% of the normal with decreased C4 level, this goes with type 2. But it is strongly recommended to repeat the test twice to confirm the results, because this is a lifelong diagnosis, and there is a consequent lifestyle adjustment and long life treatment. And at the same time, screening should be performed in all first-degree relatives of any affected individual, because this is an autosomal dominant disorder. If we found that the C1 inhibitor level normal function normal and C4 level normal, then we go for genetic testing for the minority of patients with hereditary angioedema with normal C1 esterase inhibitor, like we described the mutation either involving the factor 12 plasminogen, etc. And C4 level, although it is a very good screening test for this patient, especially in developing countries, because it is the cheapest, we cannot depend on it solely because it is very sensitive and might be just the time taken for its analysis, exposing it to variability. So it's better and recommended to do the 3 test level function and C4 level, especially if it is not during the attack. So the clues, and we want to stress on this: the recurrent angioedema, non-pitting localized swelling, recurrent extremely painful abdominal complaint, absence of fever unless the trigger is infection, but the patient is not toxic, no site of infection, there is a source of infection, not like the familiar Mediterranean fever with like FUO, swelling attacks of the upper airway, occurrence of prodromal symptoms, never there is whealing or itching, positive family history, start of symptoms in childhood or adolescence, and no response to standard emergency anti-allergic medication. Differential diagnosis of hereditary angioedema include the mast cell mediated hereditary angioedema that is associated with intensely periodic wheals, a response to anti-allergic medication, and history of exposure to allergen is common. History of drug intake AC inhibitor, but after stoppage of the AC inhibitor, no recurrence. And the acquired angioedema, onset is usually in late adulthood, late after 30 years, negative family history, and there is evidence of lymphoproliferative disorder or autoimmune disease, and the C1 inhibitor level function and C4 level are low, but there is decreased C1q level as well in the majority of cases. Other causes of acute abdominal pain, like familial Mediterranean fever, pancreatitis, appendicitis. However, the fever is not constantly present in these patients, lack of chronic symptoms, lack of toxic symptoms, evidence of isolated bowel wall edema with intraperitoneal fluid collection, resolution of findings shortly after the attack in follow-up CT scan. The treatment of hereditary angioedema involves therapeutic agent, emergency treatment, parent and patient education, and these patients should receive written action plan, what to do when they develop the attack. The mechanism of action of hereditary angioedema involves first-line targeted drug therapy, whether C1 inhibitor replacement through plasma-derived or recombinant C1 inhibitor, plasma kallikrein inhibitor, acalantide, lanadelumab, or pyrotrurestat, bradykinin B2 receptor antagonist, icatibant, and you can see that understanding the pathogenesis of this disease led to expectation which treatment would be helpful for this patient. The second line non-specific drug agent include fresh frozen plasma, which has acted as a source for C1 inhibitor, but is hazardous as we'll see, attenuated androgen, increased hepatic synthesis of C1 inhibitor, antifibrinolytic inhibit activation of plasminogen into plasmin. So we'll go through this question rapidly. Should every attack be treated? Yes, the clinical course of HAE attack is unpredictable with high morbidity and mortality of untreated attack. Therefore, all attacks, irrespective of location, should be considered for on-demand treatment as soon as they are recognized, and it should be through the first-line on-demand medication. And first-line on-demand medication includes the plasma-derived C1 inhibitor intravenous. The first one only is the one approved in the one present available in Egypt, which is Synrise. It is EMA approved for ages starting from 2 years and older, and it has no negligible risk of allergic negligible risk of any allergic reactions. The other, like plasma-derived and recombinant human C1 inhibitor, icatibant, the bradykinin receptor antagonist, and acalantide, they are not available in Egypt, but these are considered for self-administration at home, at school, except for the acalantide, which is associated with anaphylaxis risk in 4% of patients and should be given by health professional. And this is a cost effectiveness study in Italy demonstrated that treatment with plasma-derived C1 inhibitor and icatibant resulted in rapid resolution of the symptoms as compared with those received no treatment. And of course, in addition to giving the first line treatment, we have to do emergency like elective intubation once there is recognition of progression or worsening of the situation, IV fluid, antiemetic narcotic pain for severe abdominal attack, the solvent detergent treated plasma, or the, if not available, the fresh frozen plasma should be given in case of lack of availability of the first line medications. But why not should fresh frozen plasma be considered the first line? The fresh frozen plasma, as we can see in this table, I would say just mention the fresh frozen plasma, and we can see the antagonist in the intravenous plasma-derived C1 inhibitor. Fresh frozen plasma is accessible only in hospital setting. It needs longer time for transfusion. Early treatment is not possible. Time to relieve up to from 2 to 12 hours, unlike the IV plasma derived within 2 hours. It is with longer hospital stay. There is a risk of volume overload with fresh frozen plasma and higher risk of serious adverse effect. And we can remember that these patients with hereditary angioedema are otherwise normal. So when exposing them to the risk of fresh frozen plasma, I'm exposing them to undue risk for no reasons. And fresh frozen plasma, it is done in studying its efficacy in South Africa and Iran, and they found that 5 patients prior to being able to commence fresh frozen plasma required intubation, and 2 patients required intubation after the start of commencing, one because of anaphylaxis and the other because of not responding to fresh frozen plasma. And the lack of response to fresh frozen plasma is maybe because the fact that it contains factors that can stimulate the pathogenesis of hereditary angioedema attack, like the high molecular weight kininogen, plasma kallikrein, and active factor 12. Unlike the first line medication of hereditary angioedema, if the patient do not respond to the second dose, you must think in the diagnosis. You must revisit the diagnosis because they usually respond by the second dose maximum. The pre-procedure prophylaxis is recommended for invasive medical or dental procedure or surgery. And whether or not the patient received short-term prophylaxis, they should receive at hand on-demand treatment. And the first line is IV plasma-derived C1 inhibitor given 24 before the procedure. If not available, then the attenuated androgen given few days, 5 days before, and continue for 2-3 days post the procedure. And if it is emergency procedure and you cannot wait for the androgen to work, and the first line medication, IV plasma-derived C1 inhibitor, is not available, so it is time we can give fresh frozen plasma just several hours before the procedure. And the last item in treatment is the long-term prophylaxis. We should consider the level of disease activity, patient quality of life, patient preference. There must be patient compliance and the availability of healthcare resources. So marked impairment or impairment of the quality of life of this patient, they should be considered for long-term prophylaxis, especially with frequent attacks and life-threatening attacks. And there must be as well on-demand treatment at hand, because long-term prophylaxis is not a guarantee that the patient might face an acute attack, although it makes like spacing of this attack decreasing the severity. And long-term prophylaxis includes the IV plasma-derived C1 inhibitor. It's as well the one given and available. And thanks, alhamdulillah, the one available in Egypt is fit for acute treatment of acute attack, short-term prophylaxis, and long-term prophylaxis. If it is used for long-term prophylaxis, it is given every 3 or 4 days and guided by the age of the patient. The other drugs, the subcutaneous plasma-derived C1 inhibitor or lanadelumab, the kallikrein monoclonal antibody, and pyritrolostat kallikrein inhibitor, they are not available, and they are suited for patients 12 years and older. Second line include danazol, and it should only be given in patients with Tanner stage 5 and 16 years and older. with frequent monitoring, should be every 4 to 6 months because of serious adverse effects that they are common. Antifibrinolytic should be used if there is no first-line long-term prophylaxis, and danazole is contraindicated because of age or any other underlying disorder, but they are not recommended to be given because they are less effective. And this is my last slide, and I'm very sorry for making it long, but it is a rare disease that not aware of. So these patients feel a very heavy burden of the disorder, starting with the delayed diagnosis, lack of availability of the specific medication, and the consequence of limited physical activity with missed school, work, social activities, underestimation of the attack severity by the physician. Some physician might see that attack involving the extremity is not that much important. However, they do not consider how far this attack is painful, causing disfigurement and limiting the activity of the patients. They have fear and anxiety and depression of anticipating when and how the attack can occur. And because of it being genetic, there is a guilt of transmitting the disease. And therefore, patient awareness and understanding about hereditary angioedema and essential need for the availability of first-line treatment at hospital with the patients at school will help to decrease this heavy HAE burden. And thank you very much for your attention. And I would like to thank the Pediatric Allergy Immunology Rheumatology team founded by Professor Yahya El-Gamal. And again, I'm sorry for being too long for you. Thank you.
شكرا يا دكتورة داليا، أسعدتينا وأفدتينا كثيرا بهذه المحاضرة. وأنا سعيد كمان أستاذ دكتورة عزة عبد الجواد وهي بتحط البلان بتاعة المؤتمر. عملنا جلسة إميونو هيماتولوجي، يعني زي ما حضرتك قلت كده في المحاضرة المختصرة بتاعت حضرتك على الهيريديتري انجيو جبنا كام سيرة. الهيماتولوجي بقى اتكلمنا عليها كم مرة؟ اتكلمنا في فاكتور 12، واتكلمنا في البلازمينوجين اكتيفيتورز، واتكلمنا في الفايبرينوليتيك سيستم، صح؟ واتكلمنا في الريبليسمنت ثيرابي ويز فريش فروزن بلازما. ففي كروس لينك بين هيماتولوجي اند اميونولوجي، سواء كان في الباثوفيسيولوجي، سواء كان في الدايجنوستيك تولز، سواء كان في التريتمنت، سواء كان بعد كده في البون مارو ترانسبلانتيشن. فاحنا يعني نقدر نقول وحده مشتركه، او بمعنى اصح وحده مزدوجه. يسعدنا طبعا التعاون مع وحده الحساسيه والمناعه والروماتيزم باسم الاطفال. ولو تسمحي لي حضرتك بس سؤال سريع، هو مدى الافيلابيلتي اوف ذا ريبليسمنت ثيرابي with plasma derived C1 inhibitor والتكلفه الاجماليه للعيان لو هياخد لونج تيرم بروفيلاكسس.
بصي حضرتك، احنا دلوقتي بالنسبه كاكسبيرينس مع البلازما درايف سي 1 انهبيتور في اور بيشنتس ما عندناش اكسبيرينس الا عيان واحد خده من خلال يعني certain يعني زي قضيه وحاجات كده خدها. لكن النقطه في ايه؟ ان احنا we are working to يعني include this essential drug في التامين، لانه هو very important. احنا قدمنا بروتوكول يعني لانه هو حضرتك النقطه انه ده فيري اسينشال دراج. هو لو احنا جينا حسبنا، يعني هم حتى لما بره بيحسبوا، هم زي ما بيحسبوا تكلفه الدواء بيحسبوا تكلفه الميست سكول، ميست ورك، الهوسبيتال فيزيت، الدايركت والاندايركت كوست بالظبط حضرتك، والكواليتي اوف لايف. يعني هي دي حاجه مهمه في الكواليتي اوف لايف بتاعته. هو كاي بيولوجيكال ثيرابي اكسبنسيف يعني، بس هو زي النقطه حضرتك برضو الهيريديتري انجيو اديما دي ار نوت ماني بيشنتس، فلو جينا حسبناها كوست افكتفنس هتبقى في الاخر، بس احنا محتاجين الدواء يدخل وتو بي يوزد ان اور بيشنتس عشان يبقى عندنا ريل لايف اكسبيرينس، فنبتدي يعني يبقى عندنا فعلا احنا اور اكسبيرينس ككوست افكتفنس الامباكت بتاعه على البيشنت وعلى الايكونومكس اوف ذا ديزيز ايه.
احنا عايزين awareness. احنا we have a lot of cases misdiagnosed. احنا لما بيجي لنا بنديها انتي هيستامينيك وسوليوكورتيف ممكن العيان يروح. فبدات يمكن بنزول الدواء ده بدا الاويرنس. فهو هنطلب من حضراتكم زي الMBS عشان يدخل الدواء لازم يبقوا الناس اوير، ايفن حتى الGPs عشان يبداوا يحولوا، عشان نعرف انسيدنس وبريفالنس قد ايه. ونقول الدواء ده هيدخل الكوست بتاعه
والله يا
شكله
حضرتك
إيه.
احنا عملنا في يعني انا ودكتور رشا وكده لسه عاملين كان ميتنج في التامين educational على ال awareness about ال hereditary angioedema. فايمنج لان احنا فعلا شايفين ان البرايمري كير فيزيشن والجنرال بيدياتريشن ومش يعني هم في حتتين، يعني الجاسترونترولوجيست والبرايمري كير فيزيشن والجنرال بيدياتريشن ممكن هم دولت اللي يبقوا دايجنوزز. مشكله بقى التانيين اللي هو كان فيس، يعني واحد داخل مش عارف الموضوع، مثلا جراح ENT surgeon ودخل عمل تونسيلكتومي، يعني it is reported that a 14-year-old patient خلاص with de novo case that was not diagnosed before كان بيجيله recurrent لما خدوا family history بره ان كان بيجيله extremity attack، بعد العمليه دخل في laryngeal attack and he died.
بالظبط، يعني هي القصه
فهي دي مهمه
الاويرنس لكل حتى
بالظبط زي الانافيلاكسس حضرتك، يعني زي الانافيلاكسس يعني anyone can face، بس في فرق هيبقى حد كان قبليه ميس دايجنوزز ذا ديسوردر وعاملها على انها allergic او اي حاجه ثانيه، لانه في ناس مثلا لما بيبقى بالذات isolated abdominal pain بيدخلوا في a lot of investigational whether invasive او non invasive to elude انه starting from ان العيان ده somatization disorder وان دي somatoform disorder وان هو ما عندوش حاجه.
طب البريفالنس قد ايه؟ يعني انت متوقعه كم عيان؟
بصي حضرتك احنا لغايه دلوقتي احنا we have 13 patient following up in the clinic، بس التوتال اللي جالنا من خلال التامين العرض almost 18 عيان، طبعا غير الادلت، انا بتكلم على الاطفال. بس احنا مثلا حضرتك يعني احنا في كل عيله في كل يعني هو family only one family two families اللي كان ريبورتد فيهم انه ما فيش other family member affected لغايه دلوقتي. فاحنا we have to do screening first قبل ما نقول ان دي دو نوفو ميوتيشن ولا في asymptomatic patient.
بالظبط، يعني احنا عشان ندخل اي دواء في الانشورنس لازم يبقى عندنا اعداد، فاهماني؟ حتى ايفن لما جينا دخلنا الانيتيزوماب احنا خدنا اعداد عشان تقدري تقولي الكوست.
احنا كتبناها دي حضرتك، احنا كتبنا الاعداد، احنا
في البروبوزل
في العيانين دولت حضرتك في مورتاليتي 32% في العيانين، يعني احنا عيانيننا بس 32% مورتاليتي،
ده غير اللي انت مش عارفاه،
غير اللي انا ما اعرفهمش اصلا. شكرا لحضرتك.
كمان يا دكتوره داليا العيال دول بيتفتحوا كتير، بيحصل لهم اكسبلوريشن، يعني بيتفتحوا فور ابندسايتس، يعني في عيان بيتفتح اكتر من مره، فممكن هو بيعمل انتيوبيشن وعمل اكستيوبيشن معانا يبقى سفوكيتد اند ويل داي. هي القصه ممكن يبقى عدد بسيط لكن سيريس إلنس والدواء بتاعه موجود، فانا لما هستورد كميه قليله برضو.
اكزاكتلي حضرتك، اكزاكتلي. والمسج بس انه لو البيشنت از ميزد ان ذا فيرست اتاك please not to be missed in the second attack. يعني لو هو في الفيرست اتاك and is not recognized، طب second attack هو اتفتح سيرجري وبعدين كل الانفستيجيشن بتاعته ما طلعتش ان عنده underlying organic disorder، ما فيش حاجه في الكولون، ما فيش حاجه في الليفر، ما فيش حاجه في السبلين، ما فيش lymphadenopathy. Why when you have negative imaging studies except for identified bowel edema to repeat the cycle from the start and to repeat the same investigation. Think of hereditary angioedema.
دكتورة داليا أنا عايزة أقول لك thank you very much, it was great. أنتوا عملتوا وحدة الإيميونولوجي، عملتوا أكتر من سيمينار فيرتشوال عن الهيريديتري أنجيوديما والأند ريزلت علشان يعني الأويرنس. وأنا يعني أنا مش صغيرة بس أنا بشوف بيدياتريكس. أنا جالي بيشنت بأنجيوديما وأنا بكلمها خاله عنده أنجيوديما، كلمت رشا حسن وهيبقى واحد من ال 18 عيان اللي عندكم تمام، هو وخاله بقى تمام. فانا اي بليف ان الاويرنس على كل المستويات مهمه.
والله يا حضرتك انا عندي طالبه ماجستير خلاص اخوها كان في رابعه هندسه he died on the spot، يعني صحي awake from the sleep جاله laryngeal attack died.
It's greatly important. شكرا لحضرتك، وانا بشكر تكيدا علشان السبورت للمؤتمر. شكرا لتكيدا و دينا، دكتورة دينا تكيدا، احنا بنشكر تكيدا. ثانك يو فيري ماتش، شكرا ليكي. ايوه احنا بنتكلم في حاجات كتير هيماتولوجي، معلش بقى انا بعتكم عشان